Hello everyone, and welcome to the Dry Eye Debate, the Progressive Practice. This virtual event has been organised by the Ophthalmologist, and our sponsor today is Tarsus. We are very grateful for their support. My name is Alexandra Jones. I'm the editor of the Ophthalmologist. We have been extremely lucky to secure an incredible panel of world-class experts for this debate, and I'll quickly introduce them now. We have Elizabeth Yu, Assistant Professor of Ophthalmology at Eastern Virginia Medical School and Medical Director at Virginia Surgery Center in Norfolk in the US, who will be moderating and chairing today's discussion. We've got Stefano Barabino, Head of the Ocular Surface Center at the Sacco Hospital in Milan in Italy. We also have Laura Perriman, Director of Dry Eye Services and Clinical Research at the Dry Eye Clinic in Seattle. And last but not least, we have William Trattler, who's the ophthalmic surgeon at the Center for Excellence in Eye Care in Miami. And I would just like to remind our audience that our panelists are happy to answer any questions that you might have. There will be time for that at the end of the discussion. You can submit a question at any time by clicking the Ask a Question button on your screen. So without further ado, let's get started. I'll pass it over to our moderator, Dr. Elizabeth Yu.
Well, to our international audience, thank you so much. Good morning, good afternoon, good evening, wherever you are joining from. That's what our current world has allowed us to do. It really connects us virtually. And today we've got such a fantastic panel. I really do want to thank the ophthalmologist and to our sponsor, Tarsus, for allowing us to engage in a great discussion because we have such diverse clinicians and esteemed faculty with us today. I would like for everyone to go ahead and do a short introduction specifically as it relates to the type of practice that you each have and how your dry eye management actually is incorporated because as we talked about, I mean, this, while it's entitled the Dry Eye Debate, this is a collaborative discussion. This is one where we want to learn how everyone is customizing how dry eye and ocular surface disease management is actually being had, and no better than these 3 or 4 progressive practices that we have with us today. So I'll start with just alphabetical order. Joining us from Milan, Italy, as was already mentioned, Dr. Barabino, please tell us, tell me a little bit about your practice and where you are and how you are managing your dry eye center or practice. How is it incorporated?
Thank you, Elizabeth. And first of all, thank you for the invitation today. It's really a pleasure to be with you and with the other speakers today. So in terms of my experience is I see patients with dry eye and more in general with the ocular surface diseases at my hospital, which is a hospital of the University of Milan in Italy. And we have a lot of patients that are referred to us from many different parts of Italy. So we mostly see, I would say, like moderate and severe dry eye patients. In terms of research, we have a very nice collaboration with the laboratory of immunology. So what we do is actually one among the other tests that we perform is this technique that combines impression cytology and flow cytometry just to detect the expression of markers of inflammation on the ocular surface. So what I would say is that we're deeply involved in doing research in ocular surface inflammation. Other than that, we see patients in our private practice. This is typical of Italy, having like an academic position, and seeing patients also in a private practice. We see all different patients with eye problems, and in that case, I see also patients with a mild dry eye.
Wonderful, thank you. Dr. Perriman, I really want to hear about this new practice that you just built from ground up. And please tell us a little bit about the setup and how you're getting patients to come in.
Hi, thank you so much. It's wonderful to be here with all of you. Laura Perriman in Seattle, Washington. I am the founder of Perriman Eye Institute. We opened June 5th. shortly after the shutdown. Thank you so much. I've had a lot of wonderful encouragement and support from friends, and so thank you all for that. We've had a lot of fun getting this thing off the ground. We've designed everything to meet the needs of the dry eye patient from the ground up. Everything is with mindful intention to serve the dry eye patient. So that's all we do. It's what we focus on. I'm medically cornea trained, refractive surgery trained, but I'm also have a background in molecular immunobiology. And so when I heard flow cytometry, I got a little excited. So I really like clinical research. We have a clinical research program where we have a variety of trials that are either phase 2B, phase 3, or phase 4. And we have patients referred in from quite a distance. Patients will come in internationally as well because we do that deep dive and very careful, mindful evaluation and integrated treatment plan for each patient.
That's wonderful. Dr. Perriman, there is nothing to be shy about. Nerd life is the only life when it comes to ophthalmologists. So that's why I turn to you and Dr. Barabino for all of that, like higher level, sophisticated, nuanced education, information, especially with background, which we know is a little bit complex and can be quite diverse, you know? Dr. Trattler, also, if you could share with us your practice, because you know our audience is also very diverse, and the information that we provide may be a little bit more relatable to Dr. Trattler's practice, which is more private practice as compared to a very high pathology kind of academic institution.
Thank you, Liz. And I feel very lucky. I'm part of a nice institution. We're called the Center for Excellence in Eye Care. We have 15 ophthalmologists and 1 optometrist, and we're multi-specialty with oculoplastics, retina, the whole group. And my practice is specifically focused on cataract surgery, refractive surgery, and cross-linking keratoconus. And when you think about those surgeries, all those patients, they almost all have dry eye. And so such a big part of my practice is the management of dry eye before their procedures and after their procedures. That's a big part of my practice. And also, because I've been involved with dry eye just like everyone here for quite a long time, I have so many patients coming in just with dry eye. They're coming in, they have moderate to severe dry eye, frustrated, challenging, you know, MGD dry eye, and my practice is very involved in managing those patients and trying to find solutions for them.
Great. I am in Norfolk, Virginia. I'm also within a multi-specialty practice. There are a little over 20 clinicians, and we do have a strong OD base within our practice who serve as true physician extenders. They practice medical eye care, and they serve as the triage and primary care for those who are being referred in for dry eye and otherwise. As they are referred into me would be the more kind of recalcitrant and higher level dry eye. But I would say that for that part of my practice, maybe comprises 20%. The other 80% is very surgical. I love what Bill was saying about how eye surgery is a huge risk factor for patient satisfaction concerns, as well as really making sure that we are being mindful of that refractive surface, and that number one refractive surface is the tear film, and how it all interplays with our surgical patients. I do have a higher volume cataract and refractive surgery practice. I am certainly no expert in the level of keratoconus management as is Bill Trattler, and I often reach out to him for managing those patients, but certainly these patients after cross-linking, they do get dry, you know. So 2020, it's a unique year, you know, whether or not we're thinking COVID independent of and as a result of COVID, there are certainly differences and dynamic changes that we've had to implement, whether it's telemedicine or otherwise. You know, I'll start with you, Dr. Trattler. What in 2020, whether or not it's COVID related, have you implemented or changed to help improve your dry eye practice in the way you're managing and evaluating these patients?
Liz, that's a great question. I think, you know, everyone's thinking hard about how this year has been so different than every other year, and we've all made changes. You know, for us, our biggest change was we reduced our staff by about 30%. So the physicians seem to be working a little bit harder in general. But what's happened also is that the patients coming in, I see less routine visits coming in, just, hey, it's great to see you again. more patients coming with real problems, and especially dry eye. It just even though I love seeing patients for surgery, it seems that every week I see more and more patients coming in for complaints of dry eye. And so it's really been, I've been working hard just managing those patients, trying to come up with the different solutions we have now, and also some future solutions that seem just around the corner. So I'm very excited for where we are now, but I'm really excited for some of the future technologies as well.
Sure. Dr. Barabino, how about you? How are you utilizing remote medicine or telemedicine more? Are patients or different types of patients coming in with their concerns, especially with the increased use of masks?
What I actually noticed is my experience, but also the experience of my colleagues, that we are seeing a sort of like a new patients. We are seeing, probably due to the smart working or e-learning, we are seeing a lot of young patients that are complaining about dry eye symptoms. I have also teachers, academics, so probably they spend so many times in front of a screen and they develop a dry eye. So it's kind of like I would say a new populations of a dry eye patient. When we think about a dry eye, we think about like older people or like people with autoimmune disease or some other condition. But now we have this new sort of patients that we have. In terms of everyday practice, it definitely changed. We don't see patients on a routine basis. We just see patients when in need to be seen. The access to our hospital so far is limited. So we see in this case, we are in contact with our patients by using different techniques, like they send pictures, they contact us by WhatsApp or so on. And it's very much important. They really feel that they wanted to stay tuned with their own ophthalmologist. And probably what we can say is just to keep using your treatment, but still patients with the dry eye, they need it. These are patients with chronic diseases. And also there are also some a component of anxiety or like depression in some of them. So being in touch with their own ophthalmologist, I think is very much important for them.
Dr. Perriman, lots of changes, as you've mentioned, whether or not independent of COVID, obviously, but any specific changes to your practice itself of, how you're taking care of your dry eye patients, and truly what proportion or percentage of patients would you say telemedicine, is a part of it? Just any details you could provide.
Yeah, thank you for that question. So we did start a new institute June 5th. And telemedicine is very much integrated into how we onboard patients. So I think it's important to have this, at least see your patient and talk to them without this. And so I find that the telemedicine intro is very important for establishing a connection. Patients are relaxed, they like it, they're in their own environment. I'm surprised at how, well, actually I'm not surprised. There was a worry before all this happened that telemedicine would feel cold and distant and there wouldn't be that connection, that patient-physician bonding relationship, but I found the opposite to be true, that having the initial discussions and the initial risk factor evaluations with our online forms, everything's done electronically, it creates engagement. The way we ask our questions and including lifestyle questions, I think helps to create questions and awareness around the contributions of lifestyle and habits that really help to open up the realm of possibility for them of integrated care. More than just, here's your drop, see ya. That's not what we do at all. We do an integrated treatment plan, and having that platform of telemedicine and all the onboarding forms and that time together, it's like, okay, here's what you can expect when you come in. We're gonna do a very detailed examination, but all the testing, all the imaging, and we'll come up with an integrated plan. I think you're probably gonna need this based on your telemedicine photos. We've trained patients to take these fabulous photos. This technology is amazing, right? And so we can get these fabulous photos that I can get a pretty good idea of what we're gonna be dealing with in clinic. So that pre-work helps to establish the treatment, openness to the treatment plan, and also just get that busy work of the charting establishment done to minimize minimize their time in clinic.
You know, and you mentioned the mask, and that's just so important. And I'd really like to query, you guys on what you think of the mask, and we recognize that there is a greater incidence of dry eye associated with it. So this is another modern day risk factor, right? So with the mask, and if they're wearing contacts or glasses, how do those play? Do they help or worsen? Is there a relationship there? And, what are your thoughts there? I'll start with you, Dr. Perriman, because you know so much about kind of the airflow dynamics and how it relates to the ocular surface.
Oh, thank you for that question. So the short answer is D, all of the above, right? Mask associated dry eye was coined by our wonderful colleague and friend, Dr. Darrell White in Ohio. And think about it for a second. If you've got this mask here, you've got this, flora from your mouth and your nose coming up into your eyes. And so I think as we see ribosomal RNA analysis of the flora around patients, we're going to see a shift towards ENT flora around the eyes. That's probably not ideal or healthy or what nature intended. So I'm expecting not only the turbulent airflow situation, but the microbial situation to contribute to dry eye. But I do advise patients, if you're, don't make the problem worse by doing eyelash extensions. That creates even more turbulent flow and loss than just the mask alone. So it's something just to be aware of, and we do educate patients about it. I show them how to do a tape down technique to help prevent some of that turbulent air coming back into the eyes. But yeah, it's an interesting problem.
Any other input from Dr. Barabino, Dr. Trattler?
Yes, well, I agree with what Laura said. I think that since our practice, Liz, our practice is focused on refractive surgery, we're seeing a huge increase in interest in refractive surgery from our patients who are frustrated with the glasses fogging, the dryness with their contact lenses, and also even some of our cataract patients too, who are also frustrated with their glasses. So we're seeing a nice increase in those patients just because of the frustration from the airflow that's bothering them and exacerbating the dry eyes.
Yes, I agree with you. It's a problem for our patient. I don't know exactly why, what happens. Probably maybe it's the CO2 that comes out from our mouth and goes to the eye, or the flora. I have no idea, but certainly it's a problem for our patients.
Yep, I would absolutely agree. I think that certainly the mask is, I am concerned that actually the use of glasses and the use of contacts is going to worsen the airflow issues as well as the microbial flora or infestation issues because of that direct aerosolization effect that's then being further tracked, evidenced by just the fogging of the lenses. And it makes a lot of sense. It's going to, instead going into a free air, it's kind of getting stuck. So I do think that's why we may be seeing a greater incidence of chalasia, blepharitis, and otherwise. But it has had this very unique impact psychosocially and functionally within our practice surgically, whereas usually, my refractive patients are coming in because they're not tolerating contacts. So they're all inherently dry to begin with meibomian gland dropout and otherwise. They're coming in for mask intolerance, which has actually brought in healthier ocular surfaces. So at least that's the one benefit that I have seen, which is we have, better ocular surfaces to work with, which isn't something that we can always say, right? I mean, would you say it is is there any patient that we can just slide on looking at ocular surface management when we're looking at our surgical patients? Is there anyone that we can say that we don't have to worry about it? What would you think, Dr. Barabino?
I think that we, first of all, I think that we have to consider the ocular surface as a system. So I think it's tremendously important to just forget that the cornea, the conjunctiva, the tear femur are separate entities. So we have to look at the ocular surface and think that it is a system. So when you look at the patient's slit lamp, think about that. It was what I teach to my residents. And we have to check all of the system. How does it work? Is it find all the different components? I also see that there are some degrees of inflammation. This is another aspect in my opinion. Sometimes you have surprises. For example, I remember some years ago we published a paper on patients with pterygium. So pterygium is a disease of the conjunctiva. But then if you do the confocal microscopy, you see that at the center of the cornea there's an increase of immune cells and an activation of these cells. So again, in my opinion, I think that when we see our patients with a dry eye, with ocular surface disease, but more in general, for example, before surgery, we have to think about the ocular surface as a system.
That's absolutely true. That's beautifully said. Any other feedback on that question? So no, we need to be thinking about ocular surface disease. Yep. Okay, great. Dr. Perriman, there are so many different terminologies, right? There's external disease, ocular surface disease, dry eye, dysfunctional tear syndrome. You know, and yes, some people use them interchangeably. I feel like they're not necessarily interchangeable, and they are different forms, and maybe they kind of toggle, some the bigger umbrella, some under being a subset. Would you say that ocular surface disease and dry eye disease are truly interchangeable, or how do you order them? Because I think this is important for us as clinicians when we're thinking about these patients holistically.
Oh, wow, it's a great question. I'm probably somewhat guilty of interchanging terms, but and I would love to hear the rest of your thoughts on it. But in my humble opinion, it seems to me like ocular surface disease is a big umbrella term, and then you can start getting a little more specific. So let's say ocular surface disease, there's a neurologic component to that is super interesting, as Dr. Barabino just talked about. The corneal nerves become dysmorphic. So there's all that falls into the detailed buckets. But my personal feeling is that dry eye disease is probably at least 24 different diseases under one umbrella. And then over the top of that would be ocular surface disease encompassing blepharitis, meibomian gland dysfunction, you know, the neural impact of it, the immunopathophysiology, allergic conjunctivitis, all of those things come into that fore.
That makes a lot of sense.
Yeah, I agree with you, Laura. It's exactly what happens. I mean, we say ocular surface diseases, which is a disease of an entire system. Then you maybe have a dry eye, or for example, superior limbar keratoconjunctivitis is a certainly disease of the ocular surface, allergy, and so on. So I totally agree. What is important in all of these diseases is, again, to look at the ocular surface as a system. So these are diseases of a system. Just to make you an example, I've never seen a patient with a severe dry eye without meibomian gland disease. Or sometimes I see patients with a corneal ulcer, and that they are referred to me, I have a corneal ulcer, maybe like an inferior part of the cornea, and say, I don't know what to do. I've done everything, but I don't find a solution. Because the problem is that they miss the diagnosis. That corneal ulcer was due to meibomian gland disease. So that's why I think it's very much important. Some other situations, for example, you see patients with an alteration of a tear film. I say, why? Where does it come from? And then probably there's a conjunctival chalasis. If you don't see the conjunctival chalasis, if you don't think about an ocular surface system, you will never come to a definitive treatment. So again, I completely agree with you.
Yep. And Dr. Trattler, what are your thoughts there?
Well, Dr. Barabino and Dr. Perriman made great comments, and I agree with both what they said. I think that for the layperson, dry eye disease is easier term to understand, but as clinicians, we have to figure out and dive deep. Okay, why do they have dry eye? Is it aqueous deficient, meibomian gland? Is it the nerves? I mean, as Laura and Dr. Barabino mentioned, you know, there's a lot of different nuances, and we have to, as clinicians, figure out what their true underlying cause is, and that's how we can modify our treatments or focus our treatments to really help our patients. So that's how I kind of think of it. So I think I do like the terms. I don't use ocular surface disease, but I never use it with patients. I just use dry eye, and I explain why their eyes are tearing, although we still call it dry eye, which is always a fun part of the conversation. But I hope that's a helpful understanding of the way I look at it.
Yep. No, that makes a lot of sense. I think for the clinical perspective, as we're kind of ordering the differential diagnosis and the list, External disease, ocular surface disease makes sense because that's the bigger one that encompasses the different masqueraders, the different exacerbators, the other risk factors. Is there a neuropathic or a neurotrophic component? Are they hyperesthetic or do they feel nothing at all? And then of course, like for me, like dry eye, while we kind of encompass everything as dry eye when we talk about it to the patient, to me, dry eye specifically is one that involves a dysfunction or imbalance of the tear film. Every other piece of that kind of falls under external / ocular surface disease, which then leads me to, so now, you know, how are you managing these patients from diagnosis? Do you have a standardized protocol? Has that been adjusted? I love hearing that Dr. Perriman actually does a face-to-face first before they even come in. They're almost pre-interview, which then kind of eases the way, plus probably makes that in-person visit a little bit faster based on what you're saying. So clinical flow, process efficiencies being incorporated there. Bill, you know, what is that dry eye protocol look like for you? Is it the same for the entire practice?
Well, of course, you know, I have many doctors in my group and none of us agree on anything. So, you know, especially the type of treatment. So
that's great
I'm sure
to hear.
The four of us all have our strategies, and you know, I'm excited to hear what everyone else has to share. I mean, I think the challenge is that patients with dry eye, some are coming in, they've never been treated, they don't realize they have it. Others have been treated for many years. So we can't really, there's no like standard treatment. And some come in with more MGD as the issue. They may have collarettes, and we're going to really focus on that. Some are aqueous deficient. Some have, you know, they're neurotrophic. So I don't think there's a right or wrong answer. I will say that, you know, as I think about things, that I often like to use an anti-inflammatory early on, and I like to use antiseptics for the eyelash and the eyelid margins early on, and some warm compresses, and just some early stuff. But I mean, again, we can dive deep, and I think every patient we're going to treat individually and focus and try to treat them separate, you know, how they are, because it's really diverse. It's not just one protocol.
Yep. Dr. Perriman, what does your protocol look like?
So we tried hard to identify the co-conspirators and the exacerbators and address them specifically while we're also targeting inflammation. So to me, inflammation is my bullseye. And then like a Rubik's Cube, I'm trying to create a custom solution for each patient because their risk factors are different, their contributions are different. And I wanted to add something about the video interview. You can learn a lot about the entire person just by seeing them without a mask on. Things such as rosacea, co-contributors such as rosacea, dermatitis, psoriasis, yeah, you name it. There's things that you can see in just a general physical exam that can help you with that sleuthing, that customization process. So we do all the testing. We use it to guide our therapy. If the inflammatory burden is rip-roaring positive, that's going to make me a little more aggressive. If I see significant lissamine green staining on the conjunctiva, it's going to make me suspicious for autoimmune disease, and I'm going to run labs. So the testing and the examination very much fuel that information process of trying to figure out how many components are we dealing with here, and then what is my approach for each of them. And as we have more tools available to us, the innovations are so exciting. There's so many fabulous things coming to the fore that I think we'll find our protocols shifting yet again, because we'll have targeted specific things, such as specific treatments for Demodex blepharitis. Like all of these things are coming to the fore, and I think we'll see it maybe be a little bit easier on clinicians as we have more things in our toolkit.
Aha. Dr. Barabino, would you like to add anything there?
No, I do not have any standard protocol. What I would recommend to my colleagues, many times they ask me how to diagnose dry eyes. Say in the everyday practice, I don't have much time to see my patients, so you have much more time. That's why you can make an easy diagnosis of dry eye. This actually is not true, because in my opinion, if you listen to your patients, what Laura said is tremendously important. Just listen to your patients. It helps a lot. Then look at the slit lamp and think about the ocular surface as a system again, and then stain, fluorescein, and lissamine green. You get almost all the information to make the correct diagnosis. Because with the fluorescein, you see if there is a corneal damage. This is definitely secondary to an inflammatory process. And then if you stain with the lissamine green, you see many other things. For example, you see an alteration of the lid margin, so you can diagnose blepharitis. And then if you see staining of the bulbar conjunctiva, the exposed bulbar conjunctiva very probably is a dry eye with an autoimmune component, because there is an infiltration of immune cells. Or for example, if you see staining the superior part of the conjunctiva, that probably is a limbal keratoconjunctivitis. So again, if you stain, you see a lot of things. So when you have made the diagnosis, then you can think about the treatment.
Gotcha. I am going to say something, and then I would like to do kind of a rapid fire format. Raise your hands if this is part of your dry eye evaluation, just so we can, provide specific pearls, because so often we're asked, which point of care tests are you doing? Which diagnostics are you using? And I'd love to see, because we do have so much expert opinion here. Okay, so who uses a symptom questionnaire? Okay, and which one do you use, Dr. Perriman?
We do, I do several because they give me different bits of information. We do speed, OSDI, DEQ5. We ask about photophobia. We ask about impacts on mood. And so yeah, we employ a lot of them because they all tell me something a little bit different.
Okay, and which ones are validated questionnaires that you're using?
The questionnaires that we use are all validated questionnaires. We just imported the questions into a JOT form, which is a HIPAA compliant platform where you can send patients a link, and then it puts all the data in an Excel spreadsheet for you so you can analyze it later.
That's great. Dr. Barabino, which one do you use?
Same for me. And I think it's very useful, the Sandy questionnaire, because just 2 questions. And then you have the idea of how does it work compared to the previous check. So this gives you very an idea of how things are going on for the patients. And then again, also we use the OSDI or the quality of life questions. Of course, we don't use these questions in all of our patients. I'd say for sure in clinical studies, or if these patients are followed by our clinic for a long period of time.
I use a oh yes, Bill, go ahead.
Oh yeah, so I can say, well, I don't use a formal questionnaire, and I'm looking forward to hearing what you do. It's interesting, the OSDI, half of the questions are vision questions. So many of the questions when you speak to patients, you ask them, how are you seeing? Half of the OSDI is actually on vision. So if you ask your patient just, are you having fluctuation in vision? That gives you so much information. So I actually do targeted questions that I ask personally rather than filling out a questionnaire, but I'm very happy. I love hearing everyone's use of questionnaires. I think there's a lot of value there too.
Yeah, so I totally agree with you. There are some questions in the OSDI that like some sort of tricky for us, but what is useful about the OSDI that, for example, if you give the questionnaires in the waiting room, when the patients come in, you have an idea if they have dry eye or not. And also if it's a very severe dry eye or not, just to have an idea what's going on. And then I agree with you. Some questions are not correct because they can influence by the quality of vision and the visual function.
Yep. The modified speed 2, I think, is an excellent one. The ASCRS Cornea Clinical Committee actually came up with a modified one to be used in the preoperative setting for looking at dry eye for our cataract and refractive patient population. And as Bill already so keenly alluded to, it kind of combines vision, function plus speed 2 into it, which is really helpful for that surgical practice, just in case people are looking for something more focused. With point of care tests, who's using tear osmolarity routinely? What about inflammatory MMP9? Any other tear film type of tests?
Yes, such as like non-invasive tear breakup time. We'll use that as well. Not that one less routinely, but we will use that.
That's actually excellent. And what about standard tear breakup time, speaking of which?
Yeah.
Yes.
I think we have to use both of them because they give a slightly different information. Because the breakup time with the fluorescein gives you an idea where the tear film breaks, really breaks. And the non-invasive breakup time, for example, if you have a thinning of the tear film, so the machine reads as a break of the tear film. So information is kind of different. I like also these instruments that give you many informations at the same time. For example, there is an instrument, I don't say the name because I do not have any financial interest, but some of them, for example, measure the tear film thickness, conjunctival hyperemia, non-invasive breakup time, and also the infrared technology to see the meibomian glands. I think these instruments are useful, especially for screening. For example, before surgery, you want to do a screening test, you do just one test, and then you get a lot of information about the situation of the ocular surface. Having said that, I definitely base my diagnosis on the fluorescein and the lissamine green stain.
Sure. And Schirmer score.
And Schirmer scores, and you know the rheumatologist.
Routinely.
Yes, rheumatologists, at least in our country, they always ask for the Schirmer test. So we do the Schirmer test for consultation, but also we do the Schirmer test in our patients. It's just what I was taught is do the Schirmer test and forget it. Because it gives an idea of what's going on, then move forward to the other tests.
Yep. How about meibography? I get meibography on every single. That is, I think, one of the best advancements that we've had, because it surely does give you that kind of clear point in time idea of what's going on with chronicity of meibomian gland disease. And MGD is such a large part of dry eye and OSD management. I'd like to take a little bit of time to focus on the slit lamp examination. Mine in 2020 has really evolved. And the Cornea Clinical Committee made it succinct: look, lift, pull, and push. But I also have the patients look down now, which I didn't do before. I paid so much attention to the lower lid margin for MGD. I wasn't looking at the front of the lids, particularly the upper lids, which houses so much of the debris. Tell me, I mean, Dr. Perriman, what do you do with your external exam?
Well, I start with just the general, when they show up, just being able to see, here, and I have their pictures from before and that video time before. So my exam starts just seeing the person, like as from head to toe. Sometimes there's clues about the way they're walking that might make you suspect something like Parkinson's disease. So I think our exam starts there. And then by the time you get the slit lamp out with the stain, I put my stain in before. I put lissamine green and BioGlow together, stack them together, and put a drop in each eye. Then bring my slit lamp in, and I do the same thing. I look, lift, push, pull. It's amazing what you can learn about eyelid inefficiencies. Maybe there's laxity there that you didn't appreciate. Maybe there's evidence of floppy eyelid syndrome. Maybe there's superior limbic keratoconjunctivitis, as Dr. Barabino mentioned. The staining pattern is very important, and the watching under blue light, not only the staining pattern, but the way the tear film wets and spreads can be very instructive. And the tear meniscus height can be very instructive, the staining as well. But I still, to this day, look at everyone's optic nerves through an undilated pupil. It's just a habit that I can't kick.
Oh no, that makes you a great clinician. How about you, Dr. Trattler, your slit lamp exam? Do you do anything real focused with the lids? Because there's been so much attention there over the last 5 years. How are you pushing it with something? What do you do?
Exactly. Well, I will say that the first thing I look at is I'm a little different than Dr. Perriman. I don't put dye in first. I actually look before I put dye in. and I'm looking at the tear film height or the tear meniscus. I find that very valuable. And then I'll also press on the lower lids to see the secretions. And then, as Dr. Yu, as you pointed out, I more recently started having patients look down and really carefully evaluate the upper eyelids and lashes. And I had looked at it before, but I'm definitely paying more attention because I'm surprised at how common collarettes are around eyelashes, and that's really changed the game for me in a lot of ways. So that's helping me diagnose, I think, lid disease and lid margin disease a little bit easier. So, and then after that, I then
agree. Go ahead.
And then after that, then I put my fluorescein in, look at the corneal staining and tear breakup time. I think the one thing that always is helpful, and I'm sure I know everyone here knows, but it's funny, most clinicians aren't aware that when you put fluorescein stain in, the staining at 20 seconds isn't what you're looking for. You're really looking at the stain more for 2 to 3 minutes, and which is hard because everyone's in a rush. So I'll put the stain in, I'll take a look, and then I'll sometimes right the nose, actually look back again to see the stain really throughout the entire cornea. So it's really that 3-minute mark, I think, is most helpful for fluorescein staining.
Yeah, you make such a great point, and I do the same thing. I'll actually do my exam without any dyes because I want to see the natural tear film height and how it spreads across the inferior lid margin. I do pay a much closer attention now because what MGD was 5 years ago to me, I think blepharitis is, there's been so much more information that we do know there, and collarettes or cylindrical dandruff that encuffs right at the base of the lashes. It's so common, and the more I learn about it, the more I realize it's the basis of a lot of ocular surface disease. I mean, it's present in upwards of 80% of my cataract surgery patients that I'm seeing. Speaking of, I mean, what are you doing to manage, if you do see blepharitis, if you do see MGD? Let's start there. Dr. Barabino, how are you managing your current blepharitis patients?
Yes, I would say that the protocol is like a warm compresses. Then you can use different devices to warm the eyelids, but it's tremendously important. It has been demonstrated by the warming the eyelids, you can increase the breakup time by 80%. So this is very much important. It's a costless. So this is the first, definitely the first step. Then I use a tetracyclines. We have tetracyclines in the form of ointment. So the application of this ointment, for example, at bedtime is important. If it's a very severe blepharitis, maybe I can use also systemic tetracyclines, and I associate a tear substitute. And a tear substitute, we have different choices, but I think in the first phase of the disease is I need something that is very fluid, with a very low viscosity, because what I want is to increase the clearance on the surface of the eye. So in the first phase is very much important. Then if a blepharitis is under control, maybe I can choose a different tear substitute with some higher degrees of viscosity. If there is a significant inflammation, I also associate some periods of steroids, topical steroids, because again, in patients with blepharitis, we have also some degree of inflammation. So we have to treat this inflammation. I cannot tell you for how long, because it depends from patient to patient, but probably in the first phase with an active blepharitis, telangiectasia on the lid margin is important also to use topical steroids.
So what are your thoughts with blepharitis versus MGD management? Do you do any interventional options in office versus in-home options and homeopathic options? Because for certain forms of blepharitis, there's really no RX therapies that are available, particularly with Demodex.
If I see Demodex,
yep, if you don't mind, I was actually, let me get Bill's opinion too on this one, and then I'll swing it back to you.
Yes.
What were you thinking, Bill?
I didn't talk about Demodex. I totally agree with your question. It's a very good question.
Oh, I appreciate it. I'm sorry. I just wanted to get everyone's opinion on it all. Yep, go ahead, Bill.
Were you directing that question to me or?
I was. It must have been my problem where I said Bill, but it didn't come out correctly.
Okay, perfect. So great question. So what I'm doing for my patients is I'm typically using an antiseptic spray to try to kill the bacteria, viruses, and hopefully maybe a little bit help with the Demodex. So I'm using hypochlorous acid spray. I'm using warm compresses. And then if there's staining of the cornea or if I feel there's inflammation, I'm also going to add a topical steroid. If they're having irritation of their eye and burning, the topical steroid will help make them feel more comfortable and hopefully continue with the hypochlorous acid spray and the warm compresses. I know this is only an early intervention because I know that long term, I may need to go to something more like a treatment such as, tear care, lipoflow, Ilux, or something that we all have available. But it's a little costlier, so I try to do the basic stuff first. And I'm not as big a fan. I don't really love tea tree oil. It still burns my patients a little bit too much, so I've really gone away from that. And again, more using, as I mentioned, the hypochlorous acid spray.
Wonderful. Dr. Perriman?
We take a little bit of a procedural approach. I agree with all of the medications, and those are all amazing strategies. So just I agree with everything's been said. I just wanted to mention hypochlorous acid, I think it very much has a role in addressing ocular surface disease because the microflora of Sjogren's patients and Demodex patients are very different from a normal. And so I think it is important to keep the bacterial and bug component of meibomian gland dysfunction and blepharitis in mind. I call it a six-headed beasto of MGD, and so I've got to have something to address all six heads of the beasto, right? So you gotta get after all six heads of those, and the bacterial bug component is the B of the beasto. And this is just a silly little acronym I made up for myself based off of the outstanding work of Christophe Baudouin in France and Dr. Geerling, and love that group of docs too, and their excellent work. And I think Dr. Barabino has been involved in a lot of those publications as well. But anyway, yes to hypochlorous acid. When I see telangiectasias, I'm quick to offer intense pulse light therapy. So that what's so fun about IPL is that you can change the quality of the meibum, the expressibility, the number of glands yielding liquid secretions, the osmolarity, the staining, the tear breakup time, the symptom index, pretty quickly. You can get it turned around pretty quickly in an in-office way. And then what we find, and you see this again and again in the peer-reviewed literature, what we find is that then patients' home maintenance strategies are a little less burdensome. We don't have to layer on quite as much. And that it's wonderful when a patient comes back and says, you've given me time back in my day, because I don't have to spend all this time managing my lids. So I think there's a burden of disease that we can help to relieve with some of our advanced in-office treatments. So I'm quick to offer IPL when I see that telangiectasia, that ocular rosacea, that really nasty meibum that's toothpaste or not coming out at all, or turbid and thick. I'm quick to offer IPL treatment series.
That's really great information. And I think that, you're exactly right. When we're looking at the lid margin, there's so much to it, but there aren't necessarily great therapeutics that everyone would agree on, and we do it differently. And to my Dr. Barabino, who I cut off earlier, any other advice or that you can offer when you're managing your patients with blepharitis and or MGD?
No, I think it's very much important to talk to patients and explain to them that MGD or blepharitis is a chronic disease. So all the treatments that we have illustrated, these are treatments that try to control or to improve the situation, but patients have to keep using them. So for example, if you use a ointment with tetracyclines, so I recommend to my patients to use them like at bedtime for example, 1 week or 10 days per month, but they have to keep using the treatment, otherwise blepharitis comes back. So it's very much important to explain that to our patients, because otherwise they think that I do the treatment and then this is it and I'm fine, but it's not the situation. So talking to our patient again is very much important.
Yeah, I agree. Yep, so when I look at lid margin management, I also think that it goes hand in hand with what we offer in the office versus what we offer at home to do, because I think the in-office can jumpstart and provide a therapeutic effect that takes much longer, if they achieve it at all, by just doing, for example, tea tree or an oral tetracycline, because it just takes time. But the adjunctive synergy of doing like a microblepharoexfoliation exfoliation of the lid margin first, removing that keratinization, the biofilm, the flora, and then also taking whatever we need to do to maintain that MGD management, because there's so much that what you said is important, Dr. Barabino. The warmth is key. Having not just a one-time heated intervention, but then at least providing some level of heat throughout to melt the meibum so that we can prevent the recurrent obstruction, which can occur from just poor blink, reinfestation with Demodex, whatever it may be, in order to take care of our patients to the best of our ability, which just highlights again that there's limited therapeutics and we can all do it differently and it's customizable to some degree. So then that leads me to, what are you most excited about to see maybe in the next 2 years, the next 5 years, and your wish list as it relates to OSD management? Dr. Perriman, I'll start with you. What does that look like for you, to give some insight to our audience of what's to come?
Yeah, wow, that's an awesome question. So 2 years, 5 years in my wish list? That was the question, right?
Yep, you can answer all of it or any of it.
So I think at 2 years, I will have probably a couple of dozen different medications approved, and they'll be different. There'll be this new novel category of drugs in investigation and FDA trials on modulating corneal neuropathic pain, like with TRP V1 antagonists. This is a really interesting burgeoning era because the transient receptor potentials is a superfamily that modulates inflammation, corneal nerve signaling, but it's also found on the immune cells. So being able to modulate that dysfunction between immune cells and nerves, I think will be a really exciting thing. I think neural stimulation is here to stay. There's a brilliant impact with neural stimulation, particularly in my patients who have, contact lens overwear, have had prior LASIK, prior PRK, or prior cataract surgery. If there's some kind of interruption in the corneal nerve subbasal plexus, that automatic neural regulatory mechanism is damaged, and we can bypass it with neural stimulation. There's a new external neural stimulation device that was FDA approved this year, and our paper reporting our data just published a couple of weeks ago. But I think neural stimulation is here to stay. I think home care is going to see a significant uptick. Effective home care, not only the warm compresses, which are very helpful, but also mechanical lid cleaning. I've seen really great maintenance of the cleanliness of the lids with certain at-home nightly cleaning systems, which is very exciting. There's 5 years, and then my wish list. You asked me about my wish list. So my wish list is to have an in-office test to help me figure out which medication is most likely to help my patient the most. In other words, being able to analyze the tear film composition and the cytokine cacophony to predict which medication is most likely to help, but then also to track response to therapy. I would love to see confocal microscopy become a much more readily available, easy to perform in-office test, because I think that micro ultrastructural part of the dry story is something we don't have a good handle on because the technology to look at it is so expensive and difficult to operate. So I would love to see some microanatomical analysis tools coming to the fore.
That was beautifully stated. Dr. Trattler, how about you? 2 years, 5 years, wish list. What say you?
Well, there's so many exciting things that, obviously Dr. Perriman said so many exciting things to think about and to be excited about. I know on my end, the two medications I'm excited about is one, Tarsus is coming out with a very effective treatment, we hope, for Demodex, and so I'm excited for them, and I know they've been working really hard. I think both on educating clinicians that we need to pay more attention to Demodex, but then also when the medication comes out. I'm hoping it's going to be really helpful for our patients. And then another company that's developing cool technology is Zura Pharmaceuticals, that's developing a keratolytic that we'll also be using. So I'm super excited about that as well. So these are some of the medications I'm aware of. I'm sure there's so many other medications being worked on. I think that the one thing I still want to get started in my practice, but I haven't, which is on my wish list of things to do, is I really want to have more of a model like the hygienist in the practice, where I could send my patients with chronic MGD to go to see someone in my office to do heating and expression manually, like multiple times during the year. Right now, I love, I would say I love typical chair care. Other technologies work great, but there's still a price tag to them. And I wonder if we had a little less expensive option for our patients that have monthly maintenance or bi-monthly maintenance that could be really helpful for these really patients that are challenged where the home remedies aren't working well enough for them. And those are my thoughts.
Nice. Wonderful. Dr. Barabino, how about you?
So actually, I'm quite excited because very recently in Italy, we have developed a couple of things that can be interesting. The first one is a liquid form of Listen Green. It's very, very useful when it's applied on the surface of the eye. We can get a lot of information. So it's quite interesting. And then also we have developed, when I say I say an Italian company has developed a combination of a hyaluronic acid with 0.001% of a hydrocortisone. And it's kind of interesting, because there is a clearance effect of the hyaluronic acid. There are the positive effects of the hyaluronic acid, but also this very low percentage of steroids. That probably is helpful, because one thing that we are studying now is that between the normal condition, okay, the homeostasis of the ocular surface, and then inflammation, there is a stage that we call parainflammation or subclinical inflammation. It's probably sort of like positive reaction of the ocular surface. So if you have this very low percentage of steroids, you can help this parainflammation to react and to restore the homeostasis of the ocular surface. Where we have just published a paper where we divided patients, instead of like calling mild, moderate, and severe dry eye, in 3 different types of dry eye, based on how can work this response of the ocular surface system. If can restore the homeostasis, or the disease is progressing towards a chronic disease. And if I look at the future, it would be very interesting to have the nerve growth factor, the NGF, in a sort of like artificial tear containing the NGF, and it can be used also for a dry eye. It's available for corneal ulcer, but not for dry eye. So maybe it's an interesting option. And also, there's a new study that we are starting very, very soon by using a new gel that with containing progesterone is applied to the forehead, and probably it can work on a tear secretion. So some things that we are already working on, something for the future, but things are moving forward. In my opinion, the key is to find something to control inflammation over time, for a longer period of time, without inducing any side effects. Because again, inflammation plays a pivotal role in dry eye disease.
Interesting. Yeah, no, I love listening to all these different sides and facets of therapeutics that you're excited about, and kind of really brings out like your interest in where you think dry eye is and where it's going. Because for me, I think inflammation is a byproduct of certain forms of ocular surface disease. I think that ocular surface disease can lead to inflammation, but as we know, for example, early MGD, maybe in certain forms of blepharitis, different masqueraders, inflammation may be a later part of the disease course. So there's a big part, in my opinion, of OSD management that is independent of inflammation. But regardless of that, I absolutely agree that there are patients who respond well to chronic management, where they're using an immune modulator that might be less than 10%. but there are those where the acute management and kind of the cycles of dry eye, which can worsen and improve throughout the year. So this chronic intermittent kind of disease management may be a more appropriate way to manage some of our early to moderate stage OSD patients, which is what I thought about when Dr. Barabino, you mentioned the steroid component, right? I, for one, am excited to see that there are preservative-free steroids and certain steroids that will be available to help pulse dose our patients. I'm very excited about the idea of being able to have a therapeutic in just blepharitis management, and Demodex comprises such a huge part of that. And I think it serves as a sole cause or the foundational cause of a lot of diseases. And this is one that's so easy for us to diagnose. I do think that medical treatment with neurostimulation is another very exciting pathway that will have a huge uptick because it does create a very complete tear film. And in my wish list bucket, I would just like point of care tests to be more direct. I want something that's, see, like, I mean, I'm like a go, no go person, right? It's like, go down Avenue 1, go down Street L. But right now, none of them provide that because, and so it makes it still confusing. We need easy buttons, you know, for the way we are managing patients. Am I totally off base, Dr. Trattler, about this idea of periodic episodic disease management? Do you think that's real, or am I just making something up?
No, I think that patients get exacerbations with their condition. So it gets better certain times, worse at other times, you know, depending on their activities. There's so many other things that are going on in their lives. So yes, dry eye is episodic, MGD can be episodic, and their symptoms can be episodic. So identifying that with patients, talking to them about it, and coming up with treatment strategies around episodic exacerbations is really critical.
Gotcha. So you don't think I'm totally foolish for thinking that?
No.
All right. Dr. Perriman, what do you think? Is it constant inflammation, or can it be episodic? And may it be not inflammation always driven?
D, all of the above.
That's a lot.
I think that our understanding about inflammation and what we can do about it is going to grow a lot. There's going to be more emphasis and tools on modulating the innate immunity, because really what we're talking about are tools to address the adaptive immunity, which is later and can become chronic and self-perpetuating. You know, and there you get this flatline level of disease that could slowly get worse over time, but of course exacerbations come through. I think it's true of any chronic disease, and so there's very much a role for pulse dosing of steroids in a judicious way while trying to maintain, you know, preventing that patient from getting worse and maintaining that immunomodulation over the long haul. But I want to see more attention coming upstream of what are we going to do about the drivers that gets that process going in the first place, and also the reactivation of that innate immunity. And I think we're going to see some innovative tools come to the fore to uniquely address that, more emphasis on strategies to help prevent that activation of innate immunity.
That's huge.
Yeah.
Dr. Barabino.
If I make a comment, you and Dr. Perriman just described exactly our classification of a dry eye that we have just published. Because type 1 was like a,
can't wait to read your paper.
You didn't read the paper, but exactly like that. Type 1 symptoms are sporadic, type 2 are intermittent, and type 3 are chronic symptoms. And the activation of the immune system is exactly what Dr. Perriman described, like innate immunity, and maybe we come back to normal condition. But if we have a chronic dry eye with an activation of like adaptive immunity and lymphocytes, you cannot come back. So these are exactly the 3 types of dry eye that you have discussed. And this is the story, because the everyday life story is what we see in our patients. If you have a patient with a chronic dry eye, symptoms, they never go back to normal. They never disappear. They always have symptoms. Staining never disappears. And if you needed to control these patients, you need a steroids or topical cyclosporine. There are no other options. I know you have a levetiracetam in the US, is not available in Europe. It's another option, but you have to consider these patients different from the others. So again, you really beautifully described our classification without reading it, I'm sure. So thank you. It's very interesting. And it's also very helpful for the everyday practice of our colleagues. Now, we are specialists, but our colleagues need something that is very practical.
Do you think steroids can be used chronically? I know you mentioned that you're excited to see the hyaluronate with the steroids. Is this a safe and effective chronic therapy that we can use in dry eye until we know that we have more effective, immunomodulators for immune-based dry eye?
I have to be clear. Hyaluronic plus a very, very low percentage of steroids can be used as a substitute tears. So I would say in all mild and moderate dry eye can work. If you have a chronic severe dry eye, you need a full dosage steroids. What I like and what I do is to taper down the number of instillation of steroids. Just to make an example, I have patients using steroids like every one instillation every other day. And it lasts like for maybe 10 years so far. So try to find for each patient, try to find a lower dosage of steroids to control inflammation over time. If you do that, so tear substitute can be much more effective. This is what we have studied and what we are doing in our patients. So of course, you can also use cyclosporine every day, or again, leafetegrast. What is important is to control inflammation over time.
Yep. How about you, Bill?
Yeah, I was going to share. I agree with Dr. Barabino, and I'm sure Dr. Perriman feels the same way. Steroids are such a critical part of dry eye therapy, but I know that, Liz, you do a lot of corneal transplants. And I know many of your patients have been on steroids for decades, for years and decades, and they do okay. If you monitor their pressure closely, you feel it gets to a point where they can be on a safe low-dose steroid for a long period of time safely. And for our dry patients, this is a chronic severe disease we have to manage. And so I'm not afraid to use steroids long-term when they need it. I'll add in, of course, all the other immunomodulators, that we also have available. But some patients will just need some long-term steroids to really keep their condition at bay.
Yep, totally. There are a few different questions coming in. I'll direct the first one to you, Dr. Perriman. What is the role of oral nutraceuticals or omegas in your practice?
Oh, that's a great question. I encourage all my patients to be on a nutraceutical supplement. Or my personal favorite is Hydro-Eye because it has the combination of omega-3 and omega-6. You get this synergistic anti-inflammatory effect. Plus, it has the cofactors that are needed to create a healthy meibum. And I just find that, and I've seen it move the needle on metrics such as MMP9 as a monotherapy. So that made a believer out of me. This patient came in and he was a busy executive right before Christmas. They were about to product launch something. The only thing he was able to do, because he's in the tech industry, was order his Hydro-Eye. That was the only thing he was able to get done. Wasn't able to stop by the pharmacist and get the immunomodulator, none of that other stuff. Came back in the new year after starting 8 weeks of that, and his MMP9 turned negative. His osmolarity came back into the physiologic range. So I think it's very much important part of our ocular surface disease management. You are what you eat. Pharmacy, FARM, what goes in the pie hole matters, right?
How do you both feel? No, I mean, I completely agree. Every OSD patient, every patient with a little bit of dysfunction, and I want to take them to surgery, they're getting oral nutrition from me. For me also, and this is, for me, it is Hydro-Eye, but I want to hear from others. Dr. Barabino, Dr. Trattler, do you believe in it too, in its way of being an anti-inflammatory or helping to improve the meibum? What are your thoughts there?
I remember like some 15 years ago, we published probably the first paper about the use of omega-3 and omega-6, and it works. It works, and then there are so many papers showing that that it works. And I agree with Dr. Perriman. Be careful. It's not just omega-3. It's the combinations of omega-3 and omega-6. This is very much important because many people say omega-3, but actually it's not. It's the combination of the two. There should be a specific ratio, of course, but it's the combination of the two. But it has been demonstrated, for example, in studies in rabbits, that if you add to the diet omega-3 and omega-6 combination, you find them in the lacrimal gland. You find an increase in the lacrimal gland, and also you find them in the tears, and you have a decrease of inflammation. So if you have to give some advices to your patients, maybe you can start saying just eat more tuna, eat more salmon, or eat more fish in general, and it helps. Or maybe you can also say to add some omega-3 and omega-6 to the diet. I strongly believe that it works. I'm not sure if it works in all the patients with the dry eye or MGD. I do not have the proof, but I can tell you that it works.
Gotcha. And what do you recommend, Dr. Trattler?
Yeah, so we said this is a dry eye debate, and now I'm excited I get to debate all three of you because I'm a big fan of, I guess, a very pure form of omega-3. The PRN brand is one I've been using. Again, I respect that your thought process and why you're using your particular brand. I think that when I talk to my friends and colleagues, there's some that are one camp in the PRN camp, others are in the hydro eye camp, and I think they're both great products. I know there's been some good studies around PRN and its role in prior to cataract surgery and other things, and so that's the type of product I've been using, and I think we have to expand this debate in the future to really figure out which of the two forms are the best. But I think regardless of which form we choose, I think that it is very helpful for our dry eye patients.
Wonderful. That was a soft debate.
To that it's not just a matter of taking a pill. You still need to eat right, and by that, so we're constantly talking about to patients about cut down on your sugar, your grain, your wheat, dairy, soy. Cut down on those things. We recommend the Whole30 diet, which is a brilliant reset for your whole system to figure out what your food frenemies are, the ones you may love but may not be so nice to you, right? These are the Whole30 we recommend routinely, and in addition with the additional nutrition support from the supplementation.
You're just taking the fun out of
I'm such a killjoy.
I know. What about wine? Does it have an anti-inflammatory effect?
The first 30 days, no wine, but after that, resume.
What do you think? One glass red wine, good anti-inflammatory?
Probably.
It depends. It has to be Italian wine. It has to be red wine. If it's Barolo, it's much better.
Absolutely. So a couple of other questions. What do you do when you're preparing your patients for cataract surgery? They have some dry eye. Dr. Perriman, I'll start with you. I know that they're being referred for you to manage them. What are you doing for them to get them ready?
Well, I love it when a patient comes in pre-op cataract, because I tell them, it's like, listen, we've got 6 weeks to plan for the wedding day. You're about to put a wedding ring on the rest of your lifetime vision. Let's buy some flowers and prepare the hall and buy a cake and stuff. Let's get things set up for a good day, a good experience. And so we do an integrated approach. We'll do a pulsed steroids, the Nutraceuticals, an in-office MGD procedure, IPL if they need it. And it's so fun to see their ocular surface optimize, their meibomian gland function improve, because we know that cataract surgery is going to exacerbate their meibomitis, their blepharitis, etc., just by the nature of the exposure, the medications, the disruption in the neural signaling, all that stuff. And so preparing ahead of time, patients really appreciate that. And I think our colleagues are doing a really good job of being more proactive ahead of the game, instead of apologizing and trying to fix it after the game when the patient's mad at you.
Sure. Dr. Trattler, do you do anything differently? How do you counsel them?
Well, so here's the tough part. Our patients come in and they feel the reason they're coming to see us is because they can't see well. It's all because of the cataract, and that's why they're not seeing well. We have to break the news that, yes, cataract is a part of it, but the other part is they have dry eye, MGD, or the combination that requires treatment first. And so that's the whole conversation, a little bit of a challenge, because they're already focused on trying to see better with surgery. You have to say, just hold on, we need a little bit of time. My patients do want to schedule the surgery, so we'll simply let them schedule about a month out, and we're going to try to treat them and bring them back prior for one more set of readings and hope that the next visit we're going to get better readings and feel comfortable proceeding, but sometimes we do have to delay. My typical short course is I'm using a topical steroid, hypochlorous acid spray for the eyelids, warm compresses. It depends on the dry. Sometimes I'll add in, immunomodulator as well. We have 3 here in the U.S. that all work well. If I feel that they're going to need it long-term afterwards as well. That's my strategy.
Dr. Barabino, anything different?
Goblet cell impression cytology readily clinically available, Dr. Barabino, because there was a really interesting paper Steve Flugfelder published, about 10 years ago, showing that you can start to increase goblet cell density 6 weeks, and this is done in pre-op cataract patients, that the goblet cell density starts to recover in response to topical cyclosporin 6 weeks, not at 4, but at 6. And so I think there's a role for getting that wonderful goblet cell tear spreading capability, immunoregulating capability optimized beforehand. And Dr. Matosian has published some really interesting work showing that in-office thermal pulsation procedures prior to cataract surgery actually changed her IOL calculations and surgical plan 40% of the time. And that was I think their follow-up was either 4 weeks or 6 weeks. So I think you can make a huge difference in a very short period of time. John Hovannisian's paper just came out last month showing improvements in higher order aberrations and symptom scores and IOL calculation accuracy with 4 weeks of topical photographs preoperatively. So I think we're gaining evidence that these things really do work and set that patient up for success and help us get the refractive targets we're looking for.
Yep, that's, very well said. Dr. Barabino?
I totally agree with my colleagues. I think that taken together the message for surgeons, the message to surgeons is take your time. Take your time. If you see some alteration of the ocular surface system, take your time, treat your patients, and then do the surgery, so you can avoid all the problems after surgery. And we all know how frequent are these problems. We have so many patients coming back after surgery that they complain about foreign body sensation, especially or burning, or there's very serious problems about the vision if you implant in a premium IOL. If you are using a premium IOL, be very careful. The tear film has to be stable on the surface of the eye, otherwise you will have problems. So take your time before surgery. I like the idea of considering the surgery as a wedding. So you always take your time to prepare the wedding, take your time to prepare for cataract. Very, very nice idea.
That may work better for women than men, I don't know. With regards to, like, if a patient comes back after 4 weeks and they still look like they've got pretty significant staining, I always find that amniotic membrane therapy, just a short course of amniotic membrane, works really well, either as a self-retained or even doing amniotic cytokine extract. I think that's a really nice benefit because of the healing components as well as the anti-inflammatory components. I personally use Regenerize only because that's what we have, domestically. Dr. Barabino, do you have something like that in Italy? What are your amniotic membrane options?
Yes, I was actually very young when we performed the first amniotic membrane transplantation in Italy. It was done in my center together with Maurizio Rolando, and I totally agree with you. For example, you can use the amniotic membrane in different ways. One thing that we are doing from time to time is the problem is the cost of the amniotic membrane. So previously we could get the amniotic membrane easily. Now you need a bank association, so it's becoming a little bit more complicated, and it costs a lot of money. But one thing that, for example, you can do is you apply the amniotic membrane plus a contact lens and make a patch for like 48 hours. I guarantee you that if you have a staining, after doing that, the staining will disappear. So if you protect the eye with the properties of the amniotic membrane, you can definitely have some improvement. So this is what is available. The extract of amniotic membrane in Italy and in Europe are not available so far.
Gotcha. Any other thoughts, Dr. Perriman or Dr. Trattler, as it relates to amniotic therapies?
Well, no, I think it definitely helps, but I also remind that we also want to make sure that if there's a low tear film, we may have to use punctal occlusion because, I find that the amniotic membranes work better if there's occlusion of the punctum. So I typically will place a lower punctal plug. Some patients may need lower and upper plugs, but that can really be very beneficial. They have a better tear film and higher tear film when we're using those products.
Gotcha. Dr. Perriman?
Yeah, I love the amniotic membrane because, 9 months after the wedding, no, I'm kidding, but there's some good synergy there. I think of the amniotic membranes as being like a hazmat. Like I put that cryopreserved membrane on there and it just sucks up all the bad stuff and elutes all of the good stuff, the wound healing mechanism. It even converts your activated macrophages into the immunotolerant type. It's can have these regenerative properties. I call it the share molecule, the pentraxin 3 molecule. So there's just some really interesting approaches to the cryopreserved amniotic membrane that I think are very helpful. That late stage autoimmune patient, the filamentary keratitis patient, all of the severe keratitis, all these things, anterior basement membrane dystrophy, do a superficial keratectomy, throw that thing on there and their epithelium stays healed and beautiful for years after you do a procedure like that as good part of your surgical prep and getting good Ks. So yeah, in the appropriate patient. So I think that amniotic membrane is pretty awesome. Maybe we'll have twins next time.
Very sage advice. So when the honeymoon period is over, the amniotic membrane helps you keep the marriage going, essentially. So only time for a couple more questions, but this is a really important one, the psychosocial effect. There's often this generalized anxiety that accompanies with our dry eye patients. It's already complex. It's already confusing. There can be this paralysis by analysis, So when you have that, how do you talk your patient off the cliff? Are you showing them the myography? What are you doing, Dr. Perriman?
So that's a very real thing, the anxiety component for our dry eye patients. A friend of mine, Richard Adler, said, in order to treat the disease, you need to put the mind at ease. And just that sense of, I hear you, I'm glad you're here. I'm really happy to be of assistance to you. Just sitting alongside the patient and showing them that you are very much their partner in this journey, I think goes a long way if somebody feels cared for and heard. So I always start there. And then I do all these things. I think nutrition has a role in anxiety and brain function. I think depression control has a role in addressing the anxiety and neurologic, lacrimal functional unit compromise, the neurosensory compromise in our dry eye patients. So I think it's all interrelated.
Any further input? I think that was great. So another question, when it comes to these different late interventions, tear care, LipiFlow, iLux, BlephX, how do you decide who you're going to use what for? And some of it may be obviously limited to what's available. Dr. Barabino, what's available for you in Italy? And is there a decision tree if you do have different devices?
So I think that we should start simply by warm compresses. It doesn't cost anything. And you see the effect of the warm compresses on the surface of the eye. Then IPL is definitely an option. I like the IPL, especially when I see that you do not have any secretion from the glands. So probably you need something to help the glands to release the lipids. In terms of applying the worms, there are different. There are goggles. There are different other techniques. I think that they're useful, but again, hot warm compresses, for example, like with hot water, I think it's fine.
This is where the debate happens. What do you think, Dr. Trattler?
Well, I think this is a challenge. When we charge patients, a decent amount of money. In the United States, you know, the iLux, TearCare, and LipiFlow have a considerable cost to patients. There's a lot of pressure for us as clinicians that we're going to deliver a good outcome. And the results, thankfully, are quite good. Not perfect, but most patients do well. They certainly do better than warm compresses alone. I think I put patients on warm compresses and hope it works somewhat, but I know from studies that it's not going to be as helpful as these other technologies. In my center, we have both TearCare and LipiFlow. I use them interchangeably. I can't tell you that one is certainly better than the other. There's some advantages to each. But what I love, even when I do LipiFlow, I love this expression four-step that I always do, whether I'm using TearCare or LipiFlow, to manually express at the end of the procedure. And I'm amazed at, even with LipiFlow, how much extra material I get up, and with TearCare, how much material we can get up and out of those lids. And you feel really good about what you're doing for the patient. But still, the other surprise is that they don't feel better the next day. I thought when before this happened that, okay, the next day they're gonna feel great. It's not the next day, it's a few weeks to even 2 or 3 months later, they really start to feel better. So we have to continue our treatments, you know, they have to continue everything after the treatment as well, and then they'll get better and hopefully happy with us.
Dr. Perriman, that's really great advice, especially in the counseling of the patient. Dr. Perriman, what are you using, and do you have kind of a paradigm for who you choose for what for?
Yes, thank you for that. I've used all three systems, LipiFlow, TearCare, and iLux. I think they all work. They're all great. And I totally agree with what Dr. Trattler said, is setting expectations of what the technology can perform. I have found in my clinical practice that if I take the time to control the drivers of MGD, whether it's IPL for the rosacea component, the Demodex component, waking up those meibomian gland stem cells with the photobiomodulation of LLT or IPL, whatever it is you have, that then following it with an in-office thermal procedure is like this synergistic situation. There's access to care issues because of the price point, which is regrettable, but it's the state that we're in. So I find that controlling the inflammation first gives me a better outcome with my in-office thermal pulsation modalities, expression modalities, and I find that that I'm still learning on which patient actually needs something even more advanced, such as a mask and probing. I'm still learning how to identify those patients better before they go through all those things. Like sometimes you need to start with that, to almost like a heart attack victim. If they're occluded, you got to start with a stent and then work on the diet and stuff. If you're partially occluded, then you need to work on diet and exercise and all that stuff to hopefully not become all the way occluded. So there's some analogies and some synergies there. So I want to see ways to better identify that subgroup of patients that really would benefit from an invasive mask and probing. And that would help our successes as clinicians and help our satisfaction with our patients.
Yeah, excellent. I think that the lids need to be debrided, whether we're doing it manually or with like a blepharoexfoliation like BlephX before we do anything thermal. Meibography has helped to guide me. So if I do see my meibomian gland dropout, which oftentimes is sectoral, then I'll preferentially go to iLux because I know where to go after the glands that exist. If they've got great architecture, I really agree. I mean, it can be either LipiFlow or it can be with the TearCare system. And truly, you know, if it is somebody with great architecture, they will likely have improvement symptomatically, but it's not overnight. Whereas if it's somebody who has a lot of meibomian gland dropout, where you're just doing a salvage kind of rescue procedure to prevent any worsening, they need to know that too in order to set expectations. But we are running out of time. I could go on for another 90 minutes if everyone would allow me to. I don't think that everyone's going to allow me to take away the rest of their Saturday as such, but I really just want to thank everybody, Dr. Perriman, Dr. Barabino, Dr. Trattler, and to the ophthalmologist, as well as to Tarsus for the sponsorship. And I'll turn it back over to the head of the ophthalmologist with Alexandra Jones. Thank you guys so much.
Thank you.
Thank you. Thank you.
Thank you very much, everyone, for this amazing discussion. I would just like to remind everyone that this webinar will be available on demand within the next few days if you wish to revisit any of the topics covered today. And from everyone at the Ophthalmologist, thank you and stay safe. Thank you very much.
Thank you. Bye-bye.